Next, I invite Dr. J.K. Reddy, sir, to speak on corneal inlay procedures, new hope for ectatic corneal diseases.
Good evening, and last day of the last talk of the last session is it's a little bit tiring for everyone of you. So as Dr. Madhu has nicely demonstrated, you have seen this is the inlay procedures where you put a lenticule and it's supposed to work. So 7 to 8 mm size, even we used 8.5, 2 to 300, even I used 400 microns thick lenticules, 150, 200 microns thick pocket, even sometimes I used 400, a lot of combinations we tried over a period of slowly over the period of 15-20 years, and femto, manual dissection, all we tried. And this is the microceratum based one. I feel the deeper cuts, microceratum is better than femto. Femto gives a little bit bad irregularity. So in microceratum, I cut the lenticule, and pocket, this particular one we did with the femto, around 200 microns thickness pocket. Then open the pocket, and it comes very nicely. Pocket is not a big issue. You use a lot of energy there, 1.4 nanojoules to 2 nanojoules instead of 250. Generally we use around 1.6 nanojoules, so the pocket will form. Generally we make a large pocket, whatever is possible, 9 millimeters, 8.99 millimeters pocket. Then we insert the lenticule. Lenticule will be edematous initially. It looks white and edematous because the graft, it will disappear over a period of time and is spread out nicely. So we tried with the cross-linking, without cross-linking, intrastromal cross-linking, over the cornea cross-linking, cross-linked lenticules, each one of different techniques we tried over a period of time. It looks very nice. The surgery post-operatively, all can be done with topical anesthesia, and it looks very nice. Post-operative looks nice. And these are some cases, results. 3-4. The topography also improves dramatically, and the cornea becomes progressively thinner. That the lenticule thickness, initially it will be just like in DSEC. The lenticule thickness keep on reducing. It becomes from 460 to 277, something like that over a period of years. And topography also improves very nicely. As Madhu has rightly pointed out, uncorrected visual acuity improves from 660, 5/60 to 624 or 6, maybe sometimes 618, but that's not the end. They need a better vision now, people for mobility. So that's the challenge now. So DALK easily we can give around 6.9, 6.12. So we shifted to DALK, we abandoned this technique one. For example, this is a 18 years boy and 618 in the left eye. So we thought, okay, one eye is good, okay, we'll go for a insertion of the one. This is the post-operative results, and he has improved. And this is the one that is kept under 200 microns thickness, and over a period of time, the total thickness Madhu has shown 450, 500, but most of our cases are more than 600, 700 microns. The cornea thick it becomes like a rock, and then like a thick ball. So these are the post-operative results. Patients improves 1 or 2 lines over a period of time. And contact lens, of course, they improve dramatically, but our aim is without contact lens. So what we learned over a period of time with this intralenticular, what Dr. Nambata has shown with a decellularized cornea. This is not decellularized, that is a decellularized cornea which they are using from the laboratory. Lab-grown decellularized cornea. In our results, the final outcomes without contact lens are not very satisfactory, and best corrected visual acuity is not great, and quality of vision also they are not very. They say I improved very well. They never say that. They say it's okay, but they are not very satisfactory. So we abandoned some 10 years, 7 years, 8 years back. But looking back at the technique, what we learned is we are keeping a little bit deeper implant. The results are not good. If you keep around 200 microns instead of 300, 200, 150 microns superficially placed, the results are much better. Thinner lenticules, some of the results are better. Thicker lenticules, there are a lot of folds which are never getting ironed out. So the lenticule 200 microns or even 150, 160 micron lenticules are giving better results than 300, 400 microns lenticules. And the Doron should be dried. The wet hernia, you put in the artificial antechamber, put here and leave it for half an hour. So it becomes totally dry and it becomes, then you cut it. That is better than immediately doing, that's what we learned. And topography changes happens over a period of time, even 3 years, 4 years, 5 years, keep on changing. And the central cones, they do very well, and never mix with cross-linking. Don't do cross-linking. Just put a lenticle and leave it. You do cross-linking, that results are bad. And smaller the lenticules are better. 7 millimeters, 6.5, even the results are better than 8, 9 millimeters. When we did 8.5, results are very bad. When we did a smaller one, 7 lenticules, 7 only the smallest size is used, they are much better. We want to retry. Then comes the next condition, PMD, where you can see here very nice thing one, where this also can be done. We are doing our topically. We just make an incision and make with a crescent blade, with a manually done crescent blade, a pocket. It comes. This is a very soft tissue. This ectatic tissues are very soft. You don't need to worry. You don't feel the resistance of normal cornea. And young patients, naturally collagen is not cross-linked. You just pass the crescent, it get dissected. It should be a little bold. You should be a little younger. Not 40, 35 years old people can easily do it. Not at the age of 67, 65 like me, 60 years. Then put a small lenticule there. You fashion a lenticule and put it, and this is a cure. This is a cure for PMD. Don't for PMD to become worse. Once you diagnose PMD, you try to do it. You do it, it will work. Don't worry about that. So you put a lenticule there because it's not involved in the visual axis. There won't be dramatic flattening of the cornea. There will be a little bit, but you are stopping the disease process there. And this is the one, for example, this is 200 micron, 250 micron thickness. Now we got 800 micron thickness, and these are the many cases. It's a routine treatment now in our hospital for PMD. And a little bit improvement. Topographically, they are good improvement, but cylinder-wise, it will be more or less same. And these are the some more results. And this is the one, the glasses, contact lenses. We put ICL, we put a IOL, and when there is a cataract toric IOLs, even I used up to 16 diopters, custom designed intraocular lens. They dramatically they improve. You put axis, they give 6, 9, 16 diopters with 8. A little bit calculation is a little bit difficult. You don't get calculators. You have to do with your gray cells, but it works. Then coming back to advantages, topical anesthesia, no graft rejection, and you stop the disease, and you don't handle them when they are very advanced, and that's one. Then comes the new one, the CARES. It's not a new, this is our own. Susan is popularized around the world. She is Susan Jacob, and these are the, instead of PMMA, ICRS, intracorneal intacs, we are putting a corneal tissue. Right now we are using the allogenic. Maybe in future we may use a lab-grown collagen also. Right now we don't have access for that. So it can be placed around 50 to 300 microns thickness. So we again make the pocket with femto laser, somewhere between 5 to 6 millimeter, 9, 8 millimeters pocket. Then we fashion the graft. We can fashion it ourselves depending upon the topography. You can fashion different shapes, different thickness, and different sizes. So that is the advantage when compared with intacs. Intacs are fixed sizes. Here you fashion them and you insert them. The inserting technique is still not standardized. Where you keep on using that, you learn better. Each surgeon will become. So it becomes. So insert it. Right now I am using that inserter, and some people they dry it for half an hour. My fellow, my registrar, Dr. Vandana, she dries it half an hour. It becomes like a PMMA. Then just she pushes that. Half an hour she will dry that. It becomes like almost like a PMMA. Then inserts. It works very well, and the results are very good in most of the cases. So this is a 360 degrees CARES in a central cone, and visual results are really good over a period of time. And these are topographic changes that's happening. And in this case, you can see up to 11 diopters flattening with the intacs. So these are the OCT images, and Where we are going wrong. This problem is ectasia is defective collagen synthesis by keratocytes. We are just putting some collagen, but we need to answer that. We need to answer some of the mesenchymal cells in the stroma. We have to either stimulate them or put extra mesenchymal cells or somewhere from the adipose tissue derived. That's where we have to look into the future. And there are some reports are saying instead of using decellularized, we have to use a recellularized and take from the adipose tissue and grow the mesenchymal cells, put in the collagen, and we have to use recellularized cells. That looks like the answer for the future. So there are two things which in ophthalmology, generally in medical practice in the life, either we act without thinking or we keep on thinking without acting. So these two things are making the world worse place to live. Thank you very much.
Thank you so much, sir.